welcome everyone to our first in our evening MPX webinar series brought to you in partnership with the STD HIV Prevention Training Center at Johns Hopkins and the Maryland Department of Health. My name is Barbara Wilgus. I'm the program administrator for the STD PTC at Hopkins, and I'm just going to go over a little welcome and housekeeping. First off, your Zoom registration to enter the webinar, so where you entered your name and email, that's your sign in for the day, and that's how we're taking attendance. So if by chance you're using a different email for Zoom, your Zoom account, than the one with which you use to register for the course, please email Bambi Hamby at mhamby1@jhmi.edu with this information. Similarly, if you're watching in a group, please email Bambi the names of all the watchers in your group that aren't listed on the screen, because for CE credit, each individual participant needs to have registered and have watched the course. So this is how we are taking attendance. This is a webinar format, so attendees will not have access to camera or microphone. However, if you have a general comment or a technical question, you can enter that in the chat box below. If you have a question for our speaker, please enter it into the Q&A box below, and we do anticipate having time for questions and answers. These webinars are being recorded, as you know. Recordings are going to be accessible via the Maryland Department of Health MPX webpage under the section Information for Clinicians. There is the website, health.maryland.gov/monkeypox. To receive continuing education credit, you must have registered for this course via the NNPTC. You must have attended the live and interactive viewing of the course. So those who are here watching right now, and again, we are taking attendance. If you're viewing this as an archived recording, unfortunately, this does not qualify for CE. For those participants who have registered and have attended tonight, we will mark you as having attended, and we'll email instructions for how to get your CE credits following the course completion to the email address with which you registered for the course. You will have 30 days from today to go to the CDC website where we get our CE credits. And you can get your CE certificate there. You have to complete several steps. If you need any help with that, you can email Jean Huber, who is our other training coordinator. And again, that is only for the live and interactive viewing of this webinar. So a few things about the National Network of Prevention Training Centers. Here we are, the STD PTC at Johns Hopkins. We're the regional training center in teal here, but in case you're coming from elsewhere, there are prevention training centers all across the United States and territories. So if you're from somewhere outside of our region, you can look and see what your PTC is. All the regional prevention training centers provide training and technical assistance to providers in their geographic catchment area. You can also follow us on Twitter at NNPTC. Some of our national offerings that you may find of interest. If you have a clinical question for a provider, you can go to stdccn.org for free expert STD clinical consultation. You just enter your provider information, ask your question. It will be routed to an expert in your region, and you can expect your response within 1 to 5 business days, depending on the urgency that you have set. We do have an MPX section now, so if you have specifically an MPX question, that can go there as well. Additionally, one of our national offerings is with our national STD curriculum. It has been updated now for the 2021 CDC STD treatment guidelines. And this is, again, a free, up-to-date educational website, lots of CME, lots of self-study and quick reference lessons, question bank topics, a wonderful podcast series. And it's a good, innovative group learning tool, and you can assign to others in your group. So that is at www.std.uw.edu. We are doing this in partnership with the Maryland Department of Health. So I do want to note, specific to MPX, there are several resources available on the MDH website. So once you go down, there are resources for clinicians, for patients. There is actually the link where a provider can become a provider of TPOXX, which you'll learn about in another webinar. And also, this is the place where where patients can pre-register for the MPX vaccine. So again, this is all available at the MPX website, health.maryland.gov/monkeypox. And finally, an offering from CDC. The STI Treatment Guide mobile app is now available both for iPhone and Android. This is a very much more comprehensive version of the app with all things linkable. And additionally, that STDCCN website, you can directly link right through your phone using this app as well. So this is a fabulous resource now available for you right in the pocket of your coat on your phone. So I am going to now stop sharing, and without further ado, I am going to introduce our next speaker, or our only speaker, Dr. Matthew Hamill. Dr. Hamill is an assistant professor of medicine at Johns Hopkins School of Medicine, and he serves as the clinical chief for STD at Baltimore City Health Department. He's an active clinician researcher at Johns Hopkins Medicine. He trained in internal medicine, infectious diseases in the United Kingdom with subspecialty training in STI HIV. The focus of his research is novel approaches to STI diagnosis in resource-limited settings, especially the use of point-of-care tests. And Dr. Hamill has really been boots on the ground and forefront in this MPX response in Baltimore area and in Maryland as a whole and regionally. And we are pleased to have him do our first webinar, which is a MPX overall overview. Take it away.
Thank you, Barbara. Thank you for the kind introduction, and thanks to everyone who's here at the end of a Monday. Really appreciate your attendance. Please feel free to put a question into the Q&A at any point. There's something that I say that doesn't make sense or you need clarification. Feel free to put in a question, and I will be alerted about those by Barbara or Jeannie. So I have some disclosures which are on this slide, and also I'd like to acknowledge several of my wonderful colleagues at Baltimore City Health Department and at Johns Hopkins. I've set some learning objectives so that by the end of today's presentation, that you should be able to describe the natural history of monkeypox infection, identify the clinical features, recognize the differential diagnosis of monkeypox, and to describe some of the treatment modalities available. I want to move now to the epidemiology of monkeypox, and I'll start globally and then focus down nationally. Smallpox was eradicated in 1980, and with the eradication of smallpox came the cessation of smallpox vaccination. And from that time, monkeypox has emerged as the most important orthopox virus for public health. So orthopox is the family of viruses, and within that family are smallpox and monkeypox. Historically, monkeypox occurred in Central and West Africa, often in close proximity to tropical rainforests, but increasingly recognized in urban areas. There are several animal hosts which are listed here, and they include squirrels, rats, dormice, non-human primates, as well as other mammalian species. Monkeypox has two distinct clades. It has clade 2, the previously known as the West African clade, and it has clade 1, previously known as Central African or Congo Basin clade. The differences are important because the case fatality between the two different clades is quite different. It's approximately 10% for clade 1 and about 3.5% for clade 2. And the clade that we're currently dealing with globally in 2022 is clade 2B. On the right side of your screen, you'll see data that were updated last on 4/11. They're the most recent data that the CDC have available. And globally, there have been 78,229 confirmed cases of monkeypox. These have been described in 928 locations. On the map, the blue dots are the places where monkeypox is endemic, so where it's previously been found, and the orange dots are the areas with a monkeypox outbreak, sustained monkeypox outbreaks in 2022. I say the blue dots are the places where monkeypox has previously been found. Monkeypox has sporadically been found in other places, but the places in Western Central Africa on this map are places where monkeypox is endemic. So it's there all of the time. Looking closer to home, in the US, there have been to date, or at least as of November 4, 28,657 confirmed monkeypox cases. That's 36.6% of the global estimate. Unfortunately, there have been deaths associated with monkeypox in 2022. There have been 41 deaths confirmed globally, and 9 of these have occurred in the US. And again, the size of the circles is indicative of the number of people who've died in that particular place. So this graphic shows the trends of monkeypox infection. And you can see we first started to see monkeypox in May. There was a peak in August. And since then, the number of new diagnoses has really steadily decreased. This graphic represents a prediction of new infections. And you can see on the left-hand side, I put it in a green box, there's this magical R0 of 1. This is something that we talked about a lot in the early stages of COVID-19. In order for an infection to persist within a community, then an index person has to infect at least one other person. So in early days of COVID, the R0 for COVID was around 2.2 in that region. And you can see from this graph here that the observed reproductive number, or R0, has been well below 1 since around the end of July. So it seems likely that monkeypox will continue to decrease because that R0 is typically below 1. However, and you can see this on the purple bar at the end, some of the estimates, so that the estimates above the dashed line are what could happen currently with monkeypox. So whilst myself and other people will talk about, monkeypox fading away, there is still a possibility that this may not go away and that it may come back and enter into other vulnerable populations. So why have we seen these decreases? I think there isn't a single answer, and it's very likely due to a combination of different factors. Vaccination has probably played a role, behavior change, and some infection-acquired immunity amongst particular segments of affected sexual networks. So there's a link in the slides here, which I hope that you will be able to click on, which takes you to a CDC technical report. At that time of that third technical report, it was felt that the slowing seen in the number of cases of monkeypox, or new cases of monkeypox, was unlikely due to vaccination alone. I mentioned behavior change. There was an online survey of men who have sex with men in August of this year, which showed that 50% of respondents reported a reduced reduced number of sexual partners and reduced encounters. And this behavior change was a direct result of the monkeypox outbreak. So I want to change now and just shift gears and think about some of the clinical considerations, some of the clinical features of monkeypox. Earlier this year, a question that I often received was around PPE. What PPE do I need when I'm seeing somebody who potentially has monkeypox infection, somebody who's a person under investigation? And one of the benefits, and there haven't been many, but one of the benefits of COVID-19 is that we're really familiar now with PPE, and the PPE that's required when seeing a PUI for monkeypox is the same as seeing a PUI for COVID-19. So we should be wearing gown, gloves, eye protection, and a N95 filter or above. In terms of cleaning a room after seeing somebody with monkeypox infection, then standard approved disinfectant procedures using an EPA registered hospital grade disinfectant is sufficient to clean a room after a person with either confirmed or suspected monkeypox has vacated that room. Unlike COVID-19, the room does not need to sit empty for any given time, as after the cleaning has taken place and the surfaces have dried, then that room can be used again. Another question that I'm asked less commonly these days, but earlier on was frequently asked about what happens with a healthcare professional who has been exposed to monkeypox infection. So the short answer is that if somebody had an unprotected exposure, then the first thing that they should do is to seek advice around post-exposure prophylaxis, so vaccination. Healthcare workers who've been exposed do not need to be excluded from work duty, but should undergo active surveillance for symptoms for 21 days. And of course, you will notify your hospital epidemiology, infection control, and occupational health about the exposure. Healthcare workers in direct or indirect contact with a patient with monkeypox, whilst adhering to recommended infection control procedures, can go out about their business as normal. We recommend that self-monitoring or active monitoring should take place depending on the health department under whose jurisdiction you are. The next big question or set of questions is around spread of monkeypox. So we're learning a lot about monkeypox every week. I think we're beginning to learn more, but broad categories of how monkeypox is spread, I'll show you on this slide, but essentially it's spread directly from person to person, and that is through direct contact with an infectious rash, scabs, or bodily fluids. Also, through prolonged face-to-face contact where the person may be exposed to respiratory secretions of somebody with monkeypox infection. And examples would be during intimate physical contact, such as kissing. And then there's been a concern, and I think the concern is still there, but it's probably low risk when a person touches items such as clothing or linens that have previously touched the infectious rash or bodily fluids of a person with monkeypox infection. Pregnant people can spread the virus to their fetuses through the placenta. And it's also possible for people to contract monkeypox from an infected animal, either by being scratched or bitten, or by preparing or eating meat from an infected animal. The natural history of monkeypox, and when I say natural history, what I mean is that this is what happens without any interventions, without vaccination, without treatment. So the incubation period, that's what from the time that the person is exposed until the time that they develop symptoms, is typically between 5 and 21 days. It can be as low as 3, but 21 days we think of as the ceiling. So if somebody has had an exposure and they're symptom-free 21 days later, then we can be confident that that person did not acquire monkeypox infection. The incubation period is typically, though, between 7 and 14 days. And during this incubation period where someone has no signs, no symptoms, they're probably not infectious. And I put probably in parentheses because I think we are still learning about infectiousness at different phases of infection. After the incubation period, if somebody is going to develop symptoms of monkeypox, then they would enter this prodromal phase. And this is a very non-specific phase. So the prodromal features are fevers, malaise, headache, myalgia, lethargy, sometimes with a sore throat, perhaps with a cough, sometimes with lymphadenopathy. And prior to 2022, when we thought about monkeypox, we thought about it as a very stepwise disease that progressed through stages in a predictable way. So you would have the exposure, the incubation period, then the prodrome, and then about 1 to 2 days after fever onset, that's probably the most common prodromal feature, then the rash would develop. Or rarely the rash may come on earlier than that. And following the prodrome, lesions develop in the mouth and on the body, and then they progress through several stages before falling off. And a person is considered contagious from the onset of symptoms through the scab stage. The scabs need to have fallen off with regrowth of skin underneath, regrowth of new skin underneath, and that's usually around 2 to 4 weeks. So this is monkeypox as I learned about it in, in medical school and fellowship. However, we've learned that things are not necessarily the same as we previously thought. So I've mentioned here the incubation period, the prodromal features, and then the onset of the rash. And what we expect to see, at least historically, what we expected to see was this regional monomorphism. And that means that the skin lesions all are pretty similar. They're all in the same stage of evolution. So if someone has macules, then they have macules across the body. If they have pustules, then they will have pustules across the body. And these two images here show the regional monomorphism seen in African patients with monkeypox. And you can see that the facial picture on the top, that there's very consistent umbilicated lesions across the face. And then in the lower image, you can see these large fluid-filled lesions on the forearm and the hand. In 2022, we've learned that we've had our expectations challenged. And one of the things that has been really noticeable is that the skin lesions do not behave in that way of progressing sort of orderly through different stages. So what we've noticed about the skin lesions is that they're often deep-seated. So on palpation, when you examine somebody's skin, it feels like the lesions are quite deep. They often have this umbilicated center. They can be extraordinarily painful, particularly when they're inside the anal canal, and they can be itching during the cross phase. But also, the skin lesions can appear on the same person, on the same body part. You can have a macule and a papule and an umbilicated lesion and a pustule, all at the same time. There are some images here on the left from a series in Spain, where you can see different kinds of lesions that were confirmed as monkeypox. Some of them look pretty classic. Others could be mistaken for a folliculitis or a boil. On the right-hand side, you can see images from the UK. And again, they demonstrate the diversity of appearance of monkeypox skin lesions. And I just want to show you these in contrast with the images that I showed you on the previous slide. So the clinical features and the difference in clinical features that have been noted during the current outbreak is that the rash is much more likely to be in the genital, perianal, or oral area. As I've mentioned, the skin lesions may be polymorphic instead of the monomorphic presentation that we saw previously in monkeypox in Africa. We also see patients who've had no involvement of the face or the extremities. And as I've mentioned, one of the cardinal features, or one of the most noticeable features, is the anorectal pain associated with anorectal monkeypox. And then finally, the prodromal features, so the fever, malaise, they do not consistently happen before the rash. They may come on at the same time as the rash, or I've even seen a patient who developed a rash and then a couple of days later developed what we think of as the prodromal symptoms. I want to show you some images. So the next few slides are a series of images, and you can see these are images from a case series in London in the UK. On the right-hand side, panel A and B, you can see these fairly typical umbilicated monkeypox lesions around the anal margin. And then at around the 11 o'clock position, you can see where this is coalescing lesions to produce what looks like quite a firm lesion there. And then in the image below, so panel B, you can see that the small satellite lesions have healed or almost healed. However, that larger coalescing lesion has broken down again at the 11 o'clock or 12 o'clock position. The penile image in the middle of the screen again shows those two different features. It shows the multiple single lesions on the prepuce and the shaft, and then at the sulcus you can see this large coalescence of monkeypox lesions. And these coalescing lesions can be very problematic. They can break down, they can cause, a large amount of skin and soft tissue destruction. They may require operative procedures in order to manage them. One of the things that, for me as a clinician, that has been challenging in terms of monkeypox infection is to try and make a clinical diagnosis. The issue is that monkeypox can and does look like many other things that we see in day-to-day clinical practice, particularly in infectious diseases and STI clinics. And it's one of the reasons that a history is so important. So early on, a travel history, but now to think about a sexual exposure history. Those things are always important when trying to make a diagnosis. However, the travel history has become less important, as most of the monkeypox that we're seeing in the US now is via local spread. And the sexual history, again, it's important to try and capture some potential exposures that that person may have, but also it's important to be aware that people who do not have obvious high-risk exposures are also diagnosed with monkeypox infection. So I put a whole bunch of images here, none of which are monkeypox, although they all could be. And just to take you through them. So the differential diagnosis is wide, and I've just listed some of the more common ones here. So starting on the top line, left to right, there's an example of a syphilitic chancre on the penis. You see a nice kissing lesion there. And then on the right-hand side, secondary syphilis with the classic Palmer maculopapular eruption. Middle line is a child with varicella infection. Next to that is somebody, a patient with advanced HIV disease with disseminated cryptococcal infection, penile HSV, and then on the bottom row, and I put red circles around just to draw your attention. These could easily be monkeypox infection, but in fact, these are the skin lesions of disseminated gonococcal infection. And then finally, you can see some molluscum contagiosum. Of course, there are other causes of genital and anal ulcer disease that I've listed here. Some of them some are infectious and others are not. So I want to pause for breath and share with you some of the clinical features that have come across from different case series of monkeypox in 2022. So I'm going to show over the next few slides 4 case series, one from Spain, one from London, a large 16-country analysis, and then the biggest case series from the US that was published in MMWR. And I don't want to go through this line by line, but what I want to do is to demonstrate the similarities and any differences. And we can see that across the range, that the vast majority of people with confirmed monkeypox were male, that virtually all of them had identifiable skin lesions. And as I mentioned previously, fever was a feature in the majority of these case series. Rectal pain was seen, but there was some variation here between 14% and as high as 36% in the London case series. And again, as I previously mentioned, then the distribution of lesions is different from what we may have expected prior to 2022. The majority of people, apart from in the US case series, had genital lesions, and there's a substantial minority with anal or perianal lesions. And then you can see distributions on the face, trunk, hands and feet here. I won't go through those individually. So really the point that I'm trying to make with these few slides is that we have looked at monkeypox in different locations, representing different parts of the globe. I would say that they're all in resource rich countries in Europe and North America predominantly. And there have been few descriptions of monkeypox seen in sub-Saharan Africa during the same time period. A few more images here. And what these images represent is how a person with monkeypox, how their skin lesions may evolve over time. So if we look at the top row to begin with, we can see day 11, there's a lesion on the cheek and one just in front of the ear. These have started to scab by day 21. And then on the bottom row, looking from left to right, you can see this relatively small penile lesion on day 6 that had dramatically increased by day 28 and is still very visible a month after initial diagnosis. And part of the reason that I make this point is that this individual will have to be, or would advised to be, isolated at home until all of his skin lesions have healed and new skin has grown underneath. And if we think about the emotional, the financial, the societal burden of isolation with COVID-19 for a few days, and the effect that that can have on mental health and well-being, take the same isolation, but extend it up to 4 or 5 weeks, and we can really appreciate some of the non-medical burden of monkeypox infection. At the top are some oral and peri-oral images you can see on the bottom row, so panels F, G, and H. There's a lot of pharyngeal involvement, and as you can imagine, that's incredibly painful, makes it difficult for people to swallow. So one of the reasons that people are admitted to hospital is for pain relief and in order to receive IV hydration. And then underneath that, you can see some perianal, anal, and rectal lesions. And I want to draw your eye particularly to panel C, which is where you can see there's a lot of ulceration, and you can imagine why anal pain is such a predominant feature in people with anorectal monkeypox infection. This is a busy slide. That I have one point to make from it. This slide came from the Spanish group whose data I shared with you previously. But what it is telling us is that if we're going to take a swab for monkeypox, the place that we are most likely to get a positive result is from the skin lesions, so genital, oral, or anal lesions. We can also find monkeypox at other sites, including the rectum, which are represented in blue here. But what this slide really shows us is that the place in the body, or the site in the body, that has the highest amount of monkeypox is in the skin lesions. So many of you will have heard reassurance by people like me and others that the vast majority of individuals with monkeypox will recover uneventfully at home without treatment, and they will go on with their lives as normal. However, we know that there have been a number of deaths, as I showed you early on, and recently there was a report in MMWR which looked at hospitalized patients with severe monkeypox infection. This was between August and October of this year, 57 individuals. Majority were male, almost 70% Black or African American, 23% experiencing homelessness, almost 90% with immunocompromise, over 80% with HIV infection. And then the right-hand side of the screen, you can see different clinical manifestations. And I just want to draw your eye to the fact that a fifth had lung involvement, and a fifth had eye involvement, and 7% had neurological involvement, which can be one of the most serious manifestations of monkeypox infection. We can see that 93% of these individuals with severe monkeypox received oral tecovirimat, and that a little under 65% received IV tecovirimat, and that almost 30% had to receive, were sick enough to need ICU level care. So of these cases, I think one of the messages that came across was that there were delays in initiation of specific treatment. And of these 57, 12 died with monkeypox as the cause of death, and another 5 people where monkeypox was a contributory factor. And on the right, you can see some of the skin lesions of these individuals with severe monkeypox infection. So moving from the very severe manifestations of monkeypox, which thankfully are rare, but when they happen can be fatal and can certainly be life-altering, to asymptomatic infection, particularly asymptomatic rectal infection. And to date, to my knowledge, there have been 2 published studies, both from Europe, which demonstrated that between 1.3% and 6.5%, depending on the study, were able to detect monkeypox in the anal swabs from MSM who were completely asymptomatic. So what this does is to make us think about asymptomatic transmission. And as I mentioned before, we have much to learn, and this is certainly one of the areas that we need to pay attention to. And particularly if we think that monkeypox may come back in another wave, to be really aware of the fact that this may be, in part, at least the result of asymptomatic infection. So moving from some of those clinical features to a more practical consideration is how to take a monkeypox swab. And for those of you on the call who are clinicians, and for those of you who aren't clinicians but advise clinicians, I think the advice is really pretty straightforward. As I've mentioned, the provider needs to be wearing PPE. The patient should be wearing a mask. And the way to take a monkeypox swab is to vigorously rub the skin lesion. At the beginning, we were asked to unroof lesions using scalpels and needles, and thankfully, we've seen sense and no longer recommend that. What that leads to is needle stick injury and occupational monkeypox infection. So there's no need to de-roof a lesion, but vigorous rubbing over the lesion. And I do it about between 6 and 10 times, depending on how much the patient can tolerate. And then typically, depending on your lab requirements, we'd send 2 to 3 samples from different sites in viral transport or universal transport medium to the laboratory. So let's imagine you've seen a patient, you've taken a history, you've examined them, you think that they may well have monkeypox infection, you've taken your swab and you're waiting for the result to come back. What do we now say to patients? So after the clinical diagnosis, and bearing in mind that we get it wrong frequently because many other things look like monkeypox, there's some great guidance on the CDC website, the links here. So I don't want to go through these all, but just to say that we should be advising patients broadly to isolate at home, to avoid others, to wear a mask, to try and stay at home as much as they possibly can, to avoid sharing bedding, towels, utensils, and to be sure to clean common areas with household disinfectants. So you're going to have a great talk by some very esteemed colleagues of mine around the detail around diagnosis, vaccination, and treatment of monkeypox. So I just wanted to give you a sense of some of the deeper conversation that you will have as part of this series. So monkeypox diagnoses are diagnostics are offered by Maryland State Lab. They're also offered by a number of commercial laboratories, some of which are listed here, and then institutions such as Johns Hopkins, where I spend some of my time, have developed in-house tests for monkeypox infection. The tests all use the same technology. They all use PCR. However, there is a difference in turnaround time depending on the laboratory that you use. So when you've sent that swab to the laboratory and it's come back as confirmed as an orthopox, as positive for orthopox, then what happens next to the patient? And first of all, we need to inform the patient that their test result has come back and that the advice that we gave around isolation was the correct advice, and that they should continue to adhere to that advice. Let patients know that they will get a call, or they should get a call from the health department. I think it can be, it can feel very threatening or daunting for a patient to receive a call from a number that they don't know, from an individual that they've never spoken to before, who wants to discuss in detail their medical history. So it's important that we empower patients by providing them with appropriate information. That includes the fact that they will be getting a call, or should be getting a call, from somebody at the health department. And as part of that call, contact tracing will take place, and also monitoring. And it's the health department that releases the individual from isolation. I've put on the bottom of my slide, what about homelessness, shared spaces, people who come to you in clinic on public transport and you think that they have monkeypox? How do you deal with individuals who have these sorts of different challenges? I don't have the answer. Different institutions have got used different workarounds. But what I would just say is to be mindful of this, not just around monkeypox, but also around COVID-19 and other infections that doubtless we will come across over the coming years. So just to recap, a person has a positive test, most recover without complications, that symptomatic treatment, rest, Tylenol, hydration is often enough. The health department will be involved. There is a role for antivirals for people who meet criteria. Rarely people will be hospitalized, and if they are, then multidisciplinary care is required, involving plastic surgery, infectious diseases, pain management, intensive care. They're just some examples. The complications of monkeypox include, as I've spoke about many times, and I keep talking about it because it really is so important, is proctitis. People can have genital deformity, abscess formation, as I showed you with some of those coalescing lesions earlier on, sore throat or pharyngitis, enlarged lymphadenopathy, bacterial superinfection of monkeypox lesions, and rarely, thankfully, encephalitis or involvement of the brain. There's concern about the scarring that follows monkeypox infection. I think to date, thankfully, I haven't seen anybody who's had mild disease who's had problems with scarring. However, I think that we still have much to learn about the long-term complications of monkeypox infection. So I will just mention, sorry, I skipped past that. In terms of supportive care, then pain control is something that is important that we take seriously. Often the degree of pain is completely not keeping with what we can see on what we can see on exam. So somebody may have excruciating pain, and all you can see is a couple of perianal lesions, for instance. But if you were able to look inside, then what you might see is the same as I showed you on some of the images, with lots of ulceration inside the anus and up into the rectum. So for oral lesions, people can use saltwater gargle or viscous lidocaine, so lidocaine that sort of stays in the mouth. For rectal symptoms, suggest stool softeners. Again, topical lidocaine can be helpful. Trying to avoid opioids because that causes constipation, which then makes defecation even more painful. So people trying to avoid defecation, they become constipated. They become constipated because of the opioids. So this vicious cycle can come into play. We should stay in contact with our patients because often they're frightened and often they're isolated. Non-steroidal anti-inflammatories can be good, although we should use them with caution, particularly if people have underlying renal disease, for instance. So tecovirimat or TPOXX may be indicated for pain as the specific indication. So I'm just going to finish with a couple of more slides. The first is on treatment. So tecovirimat or TPOXX is available. It's a medication that's given either orally or by the intravenous route for 14 days. If it's given orally, it needs to be taken 30 minutes after a full meal that has a moderate fat content. And on the right side of the screen, you can see the different groups of people who should be considered for treatment with tecovirimat. We don't know about the efficacy of tecovirimat. We think from very small observations that it may be helpful in the treatment of monkeypox infection. However, we don't have efficacy data currently, and that's something that we are trying very hard to get. And I'll come back to explain what I mean by that. Tecovirimat can have people who take tecovirimat, they can have adverse reactions, and some of them are listed here. But what I would say is that generally speaking, that tecovirimat is really very well tolerated, that people will take their oral medication, they'll take it for 2 weeks, and typically they'll sail through their medication without any major adverse effects. I talked about needing efficacy data, and I'm showing this slide. This is the STOMP study. This is the study of tecovirimat that is being run by the ACTG, the AIDS Clinical Trial Group. I am the investigator of record here at Johns Hopkins. We are just in the final stages of our IRB approval, and then we will be able to accept people with confirmed or probable monkeypox into a trial where they will be randomized 2-to-1 to receive tecovirimat versus placebo. People with severe disease, including severe pain, they will not be randomized because it's not ethical to do that. Even though we don't know about the efficacy of tecovirimat, those individuals will go on to open label. So in the third arm, a non-randomized arm, where people will receive open label tecovirimat. This is a national study. The number is there that any healthcare provider can call if they have somebody who is interested in taking part in this study. And this is really useful for people with mild disease who don't qualify for tecovirimat. This is a good way of those people accessing treatment should they want treatment. And I'll finish on vaccines. Dr. Noreen Hines, who's a global expert, will really tell you about monkeypox vaccines. But just to say, there are two. The one that we are using primarily is the Jynneos vaccine. This is contraindicated in people who have severe allergy to eggs, ciprofloxacin or gentamicin. However, it is safe to administer to people with immune compromise, particularly people living with HIV and those with inflammatory skin conditions. In August, the FDA allowed us to change the way that we administer the Jynneos vaccine. Instead of giving 0.5 mils subcutaneously, we're able to divide a single vial of 0.5 ml into 5 different 0.1 ml doses that can be administered intradermally. I will skip over this other than to say that there are different strategies for administering vaccine. There's pre-exposure prophylaxis, there's post-exposure prophylaxis, such as somebody who comes into contact with monkeypox either occupationally or sexually. Ideally, we want to give that post-exposure prophylactic vaccine as soon as possible, certainly within 4 days after exposure. However, it can still be used up to 14 days after exposure. So I'll finish here. I'm really happy to take any questions, comments. If you have experiences to share, please let me know, and I'll try my best to answer any questions that you have.
Okay, does anyone have any questions for Dr. Hamill? You can put them in the Q&A while we're waiting for everyone to think of a question or type. I will start off with one that I asked earlier today in a national webinar, which is given kind of where we are on this side of the bell curve, but also not knowing if it's about to be like a bell curve that goes like this, as opposed to just, you know, away. What would be, so with cases currently more on the decline than not, what would be your advice to patients who are seeking care with concerns about monkeypox? And then also, what would be your advice for providers who are not really sure how to set up their infrastructure, things like that? What would be your advice to those two very important and different populations of people?
Yeah, thanks for that question. Really important. You know, I think that we all appreciate that the case rate is falling rapidly, but we don't know what's going to happen in the future. In terms of the sort of big takeaway points to patients, or people at risk of monkeypox infection. And bear in mind that anybody can be at risk of monkeypox, and anyone can acquire monkeypox if they have an exposure. We've focused a lot, and appropriately, I think, on men who have sex with men, because that's the vast majority of cases that we've seen in the US. But I just want to make the point that anyone can be at risk and can acquire monkeypox. So for those individuals, then vaccination is absolutely critical. That it's a two dose schedule at day 0, and then 28 days later, and then full immunity is thought to occur around 2 weeks after the second dose. And that is, again, we don't really have great data, but we think that the efficacy of vaccine is around 85%. So I think one way that patients can empower themselves is through knowledge of vaccination, and we can help to provide that knowledge. In terms of providers, in some ways, this to me feels like a more dangerous time. Dangerous is probably not the right word, but it's a time, I think, where we appreciate that monkeypox is on the wane. I think that, as is human nature, when things aren't, sort of in the news a lot, or we know that case count is falling, then it can go to the back of our minds. And I think that providers may just stop thinking about monkeypox as part of the differential diagnosis when they see somebody with a skin lesion, and they think, yeah, that's absolute barn door classic primary syphilis. So I think this is a time that we need to keep our attention on monkeypox, to think about it and appropriately test when we consider that somebody may have a clinical presentation consistent with monkeypox.
Okay, and here's a question. What name are we calling monkeypox? Mpox, MPV, or MPX? Or all of the above?
Yeah, I think all of the above. I've certainly heard all of the above used in different fora with different people. Some people are more comfortable with the current, more scientific name of monkeypox virus. Others feel that there's stigma associated with that terminology and prefer to use a truncated form such as MPX. So I think that if you're asking how we refer to it as healthcare professionals or providers, then I think that we should be led by our patients, and we should ask how they would like to discuss this and what language they would like to use. I think my experience is that patients have been talking to me about monkeypox. That is the language that they use and seem comfortable with. So I've been responding in the same way, but I think that we should just be sensitive to the fact that that this is a stigmatizing condition, particularly in certain communities. So just to be mindful of that. Barbara, thank you for noticing the 411. I've been in the US for 5 years, and I don't get this wrong anymore, but you can see that occasionally occasionally I slip. So thank you.
It's not wrong.
Right, relatively speaking.
It's language or numbers, I don't know.
Yeah.
All right, well, if there are no further questions, I want to thank Dr. Hamill for this wonderful overview, and remind everyone that tomorrow we have a webinar going in depth into clinical management. So everything that you would want to do after someone has been diagnosed with monkeypox or MPX. And then on Wednesday, we have an in-depth nuts and bolts of testing. So how you actually get from person walking in the door to diagnosis. And then we'll wrap up on this coming Monday, the 14th, with our webinar on vaccines and everything you ever wanted to know and some things you didn't even know that you wanted to know, and you're going to learn anyway. So it's going to be a great evening, week ahead. Thank you for everyone who has come very much. Thank you to Dr. Hamill. And we look forward to seeing you at another training. Take care, everyone, and have a good evening.
Thank you.